All right, I'm still trying to manage this. Okay, so I'll go ahead with my topic, managing the COVID-19 in clinic and case studies for ULTRAFORMER 3. I'm currently working in Taiwan at Adventist Hospital in charge of the dermatology and then also the International Priority Care Center. And then also the Stem Cell Therapy Committee. First of all, I would like to talk about managing of the COVID-19. Okay, coping with the COVID-19 in Taiwan. I'm in the hospital base, maybe kind of different. Maybe kind of different from some of the other doctors shared from the clinical setting. And this is the picture of me fully gear up. This is a picture of my hospital, our hospital in Taiwan, Adventist Hospital. The hospital is established in 1955. And then it belongs to Adventist Healthcare Association. And there were many, many sister hospitals around the world. For example, from Korea, in Seoul, in Busan, and also in Japan, Tokyo, Kobe, and also Okinawa, and also from Hong Kong too. It's home-based in states, Loma Linda University, and also the medical center. Yes, and then the hospital right now is about, we have about around 400 beds, and then about 1,000 staffs, including more than 140 physicians. The hospital is a mid-sized regional hospital. It's located just right at the center of Taipei. And it's a single-payer universal health care in Taiwan. And then it's well known for taking care of the international patients. For example, 1/3 of my patients were mainly the foreign friends. And it's either for them to reside in Taiwan or they visit Taiwan, the travelers. So our hospital is kind of well known for taking care of the international patients. And this is kind of special, especially during this COVID-19 situation. And this is the banner of my the dermatology and aesthetic department. And then right now the banner is more like the exhibition in front of the hospital. This is how the aesthetic center is, the layout of the aesthetic center. So what's the responsibility during this pandemic from a hospital base? We have to protect our staff. We have to screening for and treating the COVID patients, and also caring for and protecting the non-COVID patients. And then absolutely, we hope there is no in-hospital COVID outbreaks, and actually there's nothing like this happened. And hopefully we hope there's no missed COVID-19 patients, and also continually providing the healthcare to the non-COVID patients. Remember what happened to us 17 years ago during the SARS. So our mentality fighting the COVID is how we've been prepared for the past 17 years. We knew that we were in our own, and then we need to have a very quick response. And then the fairness to the patient, to the staffs, and also the trusting the government and not becoming the weak link. And then the responses were from different aspects. Let's say from the organization, also including the space allocation, from the personnel, the communication, innovations, and we also get a donation from the private sector too. And as in the organization, the COVID-19 response team was established in very early January, and it was led by our president and also the VP of the Medical Quality Control and Infectious Control. The members, including the top management from different departments, and we have our weekly meetings with a real-time chat group. And then the temperature was taken for all the people entering the hospital in the very, very beginning of the February. The TOCC history taking is taken for all. And patients with fever or COVID-related symptoms and TOCC are diverged to the temporary tent set up outside of the hospital. And then what I'm saying this is kind of important for me too, because I'm not only a dermatologist, I also provide those aesthetic treatments. And the aesthetic center is just located inside the hospital. So for all the patients who enter or for all the customers, if they're thinking or asking for those treatments, they also have to go through all those TOCC checkup. And then all the tests are done in a very specific areas, including how we get the sampling of, from the nostril or from a sputum, and also the blood check. And all the confirmed and suspected patients are sent to a designated COVID floor. Before the outbreak, we had only 3 negative pressure isolation rooms, but only within the 3 days, we reorganized the whole floor and readjusted to a negative pressure rooms. So all the non-COVID internal patients were reallocated to the other ward. And the phase 1, we had divided to the non-COVID patients and the COVID wards. For the COVID ward, it has to be negative pressure area. In phase 2, during the time we consider as more patients, or in a more, we're saying about risk period, we converted the whole floor to the COVID ward. And then we clear divides for those people who can actually go in to this control area. They have to be fully geared, and then in order to go in. And then we kind of communicate with all the doctors or other staff through this, through the web, through the also this digital camera. All the personnel, the total involvement of all the staffs in the hospital has to get involved. So the closure of the hospital gym and then cafeteria, I have to say, inside the hospital, we have one of the biggest gym just inside the hospital. All the community customers or patients or even the staffs, we can enjoy the gym inside the hospital. But during this COVID-19 is closed. And then also there's the transparency of the tests and the expectations, and avoiding crossing COVID barrier if possible. And then we give extra education to the janitorial and also the supportive staffs. We have to make sure all the staffs and also the janitorial personnel, they are not in the risk of getting this COVID-19. So even one patient occurred within our staffs, we're thinking about, we know that it's going to influence the whole hospital. So all the full-time doctors under 55-year-old, including me, were assigned to rotate on duty night shifts for the COVID ward. Even I'm a dermatologist, but I believe I got trained. Before I become a dermatologist, I also get trained for all the internal and also the surgical skills too. So I think in this very critical time, no one can escape from this situation. So all the doctors, we have to get used to what's going to happen and what we can deal with during this COVID-19. And also a national-wide general healthcare training for all the specialists after the SARS. So we have the knowledge of taking care. Of course, we got to be re-educated too. And we have the survival guides for the COVID duty doctors. Through the implementation of the staff health status report systems, the testing and the self-isolation of the workers with any symptoms, and all the hospital staff were tested if they had any related symptoms, and returning to work only negative test results. This is the communication between other hospitals. We're learning from the peers, and with our staff, finding out the needs and the places that are vulnerable. And then we have to communicate with our patient too, because they are they're afraid, they're anxious about the situation too. So we have to comfort them too, and then we have to communicate with the government. As for the patients and family, if there's no TOCC check, you're not allowed to enter the hospital. So for all the citizens in Taiwan, we have a special card. We just have to put in the machine and we know where you go for the past 14 days. But how about when I said we have a lot of the international customers? As the leader of the chief of this international priority care center, we have another set up the rule that we have to check on the phone and ask them and their traveling history prior to they come to the hospital. And also, we also check their passport and to see when did they enter Taiwan. So we do a very, very strict control before they enter the hospital in order to protect, to give a safe and comfort environment for inside the hospital. And only a single accompanied family member is allowed. There's no visitor allowed in the hospital during this the past 4 months. And one daily surgical mask is provided to each in-hospital patients by the government. So communication with the government, we trust. We have to trust and trust the information as transparency. There's a sentence was saying and posted in New York Post and saying that Taiwan makes sure that its health institutions are hyper vigilant about epidemic risks. And after the SARS epidemic of 2003, if there's a threat is detected, containment plans and supply stockpiles are already prepared. And that process starts at the bottom and not from the top. So most things were done before the official regulation at almost all the hospitals and doing what we thought was right and trusting that authority would support us. We have the innovation. So we have the outdoor prescription refills. So for the patients, only to refill those, let's say hypertension, DM, there's long-lasting underlying diseases. They don't necessary to come into the hospital. They can just refill their medication outside the hospital. It's more like a drive-through. So keeping at-risk patients out of the hospital. And innovation for social distancing is confined the space during the, let's say, dining. And also non-essential meetings are all canceled, all changed to online conferences. We also have the innovation for the quick video surveillance installment in all the isolation rooms. And all the PPEs, always thanks to the hospitals, thanks to the government, we have all the gear up to protect the medical staff too. We have protected facial shields, the goggles, the hairnets, the gloves, the protecting gowns, a surgical mask, N95 respirators, and 4 body protective suits is necessary in order to go to the COVID-19 ward. We have sufficient stockpile and supply. And then careful management and post-outbreak, an ongoing struggle between the safety and also the conversation. And then we have to have the guidelines for the PPE for different kind of situation. For example, for the personnel in front, in the front gate, they don't need to be fully dressed up, only the basic protecting gear that will be necessary. The rolling adjustment of the criteria. So as the testing capacity is increasing this pandemic, there were more regulations from the related TOCC. So 2 highly suspected cases with or without related TOCC, we only test those patients that we highly suspect of or with the highly suspect of the traveling history symptoms, and to any patient that's clinically suspected with with pneumonias. And then mostly the general public cannot ask for the test for no reason. And once you think you want to be tested or a doctor thinks you are to be tested, then your name will be reported to the hospital, to the government. So in conclusion, we need to have the total staff involvement, the transparency with the good communication, and the bottom-up decision-making, simple, good, enough solution on time. The Taiwan, the country is reopening within Taiwan at June the 7th. And then thanks to everyone's effort from the citizen, from the government, and there's 0 new cases reported at June the 10th. So right now, there's the relaxing measures. The tents were removed. There's no more tents in front of the hospital. The COVID ward was downsized to phase 1, and our gym was reopened first to our staff, and then later on to the public. And then the TOCC checkpoint was removed. Right now, we only check the temperature because we know that in Taiwan, all the citizens in Taiwan or all the foreign friends in Taiwan, right now at least, they have more than 14 days stay in Taiwan. So the traveling is not that important comparatively, but the temperature and symptom we still have to be aware of. So it's going back to normal. We're keeping vigilant with all the patients, staying alert about chance of outbreak in Taiwan, and always ready to jump back into the action if we need it. And then after the SARS, this is the normal for hospital in Taiwan. So as in the hospital setting, the aesthetic center inside the hospital setting, all of our patients, they visit the hospital, they have to go through the very, very strict checkup. But so will that influence the amount of the patients and the customers? Yes, of course. Starting from the March until maybe the end of April, beginning of the May, there's about 1/3 to almost 1/2 of the customer decrease. But but I have to say, because it's a hospital base, and we have a very good bonding with our customer. So the customers start to come back starting from May, and right now in June we are almost back to our normal expectations. So that was about my brief introduction and sharing of how we deal with COVID-19 in the past 4 months. So I will continue to the topic, another topic today. So I put out the topic as what is more to be expected, the skin rejuvenation by utilizing the 2mm probe of this high intensity focused ultrasound. Sorry, let me make sure that this is. Okay. It's been long down. Okay, let's start with this topic. The reason I choose to talk about mainly focus on the 2mm probe cartridge is because that, of course, we have no doubt, and I have no doubt about using the other cartridge, the 6mm, the 4.5, the 3mm, or combination of all of them in treating and lifting for the indication, or even they have the 9mm one, or I'm expecting there will be even deeper depths cartridge to be introduced in Taiwan. The focus will be on 2mm is also because that the customers in Taiwan and also the Asian customers, I think we care about this delicate stuff, not only the lifting, but also, let's say, the periorbital, and also regarding the neck, the line around the neck, and also the pigmentation. Will there be any chance that this ULTRAFORMER 2mm cartridge can provide some benefits in this 3 category. I understand that the Dr. Franz and then everyone might be, I'll be very familiar with this high intensity focused ultrasound, the basic principle and mechanism. But just give me 5 minutes or 3 minutes to quickly go through the basic idea, mechanism of this HIFU. So this is the procedure that bypasses the surface of the skin and delivers target energy, and specifically into the deep structural tissue and muscles where the collagen lives. It created what we call a thermal injury zone. It's about 1 millimeter coagulation point. And during the healing process, it increases the collagen. And as the collagen reorganizes and shortened, and the tightening effect can be seen clinically. So during the first inflammatory phases, the energy was delivered down to the dermis or even to the deeper to the fat layer. And then inflammation around of the skin tissue followed by a natural process of this fibroplasia and also the migration of the new connective tissues to the wound healing process. This is all we know about the wound healing process. And also then we go into the remodeling phase. The granulation tissue forms around the wound and inducing a tighter and more uniform buildup of these collagen fibers. So let's be more focused regarding this macro and micro focused ultrasound. So as for the macro, we're expecting the energy delivered will be higher. So even to induce a lipolysis effect. And as for the micro focused, we're expecting the thermal injury zone to be focused around the dermis, either the deep or the shallow dermis, to creating the tightening effect. Here shows a skin biopsy that revealed, first of all, in A and C. This is a significant loss of the collagens and then elastic fibers before the treatment. And then after the treatment, we say increases of the dermal collagen and also the elastic fibers in the reticular dermis. How this is HIFU aesthetic application evolved through this past 10 years. At first, there was the ULTRA, and then the indication was for the eyebrow lifting, and they had 1.5, 3, and 4.5 millimeters. And then in 2014, there's the ULTRAFORMER 2, and the indication was also on the eyebrow lifting. Then, at the same year, other HIFU devices just like booming and coming out, but all the indications were also on only eyebrow lifting. Then the ULTRAFORMER 3 introduced in 2018. There's a lot of invention and then improvements and then there's new ideas regarding this newer depths of different cartridges, including the 6 millimeters and 9 millimeters. So of course, there will be more indications, clinical indications for the treatments. For example, the chin lifting, and then also the cheek, and also the abdomen, and also the thigh tightening. And then at the end of 2018, there was the introduction for the newly invented 2 millimeter cartridge. And in Taiwan, we had it like in the early 2019. And that was the time I started to have a chance to use this 2 millimeter. I was astonished by this cartridge. So what's good about this ULTRAFORMER 3? I like about it comparative to the other HIFU I used before is because it was assembled by the dual engine for which that can provide a higher peak power. A higher peak power, that means that I can introduce better or higher heat heat to the target lesions and without damaging too much of the surrounding tissue, and also yielding less pain and minimal side effects comparatively, and also more. What I'm saying is, what I'm seeing is also a more effective results. Here are the family of this ULTRAFORMER 3, the 4 depth cartridge coverage, including the 1.5, 3, 4.5, 6, 9, and then the 2 millimeter. And I'm expecting there will be more cartridge to different depths. So the more cartridge that we can use, and the combination that we are thinking we can provide the patient, the customer, with a combination of different depths in order to provide, to see a different beneficial effect, including the brightening, the fine wrinkles, the eyebrow lifting, also the infraorbital laxities. This is what I observed, what I see was quite a originally our expectation, and what I see right now is more like uniform results. So the micro and the macro focused ultrasound, this micro focused ultrasound, it uses the 4 megahertz and also the 7 megahertz transducer that's the coagulation into the dermis and also the SMAS. And then for the macro, this is the 2 megahertz transducer and all the way down into the subcutaneous fat that can selectively remove the fat cell, or what I say is the lipolysis. So the aperture of this macro focused macro cartridge, we can see it's bigger compared to the facial cartridge. Also the aperture, the energy it provides, we have different kind of expectations. So this is why we say what's good about the macro and macro. The new 2 ml cartridge is compared to the other type of this, we said the shallower cartridge. Comparatively, we can see right away the aperture is smaller. That means I can provide this treatment to a very delicate regions, and then that can, for example, to the places that were difficult to reach compared to other type of the cartridge that designed. Okay, so with this special the invention, the better field vision by 75%, and it's easy to perform the treatment with safeties. So it's significantly, I can reduce the fine lines just around, just periorbital, and also the wrinkles, and also around the forehead, around the peri-oral region too. And comparatively to the other type of the cartridge, that's difficult to reach those difficult reach areas. Let's take a look at some pictures of how I can align this cartridge when I provide the treatment. But I have to say, for the periorbital treatment, I'm not only aligning the cartridge perpendicular to our eyelid, but I also do some parallel, this cross-linking kind of treatment that what I see is provide a better clinical results. So with this kind of design, the physician are 20% faster comparatively to give the shooting speed and easier access to the hard treat regions, and patient can feel less discomfort because I can do the treatment faster. And I have to say, this is the feedback from the patient is that it's the procedure is comfortable, and then I can finish the whole upper part of the face, starting from this infraorbital region all the way to the forehead with 300 shots. Totally, I can finish it within 15 minutes. So why 2 millimeter? What's good about 2 millimeter surrounding or around this orbital region? There was a study published in 2005. The doctors, the groups, the scientists kind of judge, or let's say they did a study in cadavers, and then saying that if the upper eyelid is about 1, then what's the relative ratio of the thickness ratio in other parts of the face? So if the upper eyelid is 1, then relatively the other parts of the facial region were listed or indicated as the chart we see over here. Then there's another study. Sorry, I need to go back. And there, this is the first study was this study in 2005, and then This is the second study done by a Korean group of doctors from Korea. And then they studied what's the actual the full thickness of the upper eyelids comparatively in those Korean populations. So the upper eyelid, I'll just make it simple, where relative thickness was about 0.75 millimeter. So let's say I can say if we combine in this theory together, then we can actually give rise actual the thickness of the periorbital or the infraorbital region, the lower eyelid region. So this is accordingly, let's say chin is about 2.36. This is the thickness of from the epidermis down all the way to the dermal thickness. And then the lower eyelid is about 1.65. The forehead is about 2.14. Okay, here goes that. What does it look like when we have this macro and micro focused ultrasound? And when we give it a try, how does it look like on those transparent sheets? This is how it looks like for the macro cartridge. It delivers a bigger coagulation, thermal coagulation zone. And this is the macro, the micro dots. And then, so the MF2, the 2 millimeter one, the cartridge will be the micro one. So this is how we can compare the micro dots, the micro thermal injury zone it created. So okay, let's go back to, let's be focused on our periorbital treatment. I'm going to share some of my cases. So why periorbital bring our major concern is because aging of the periorbital region involves a complex series of anatomic and physiological changes that occur over the times. The periorbital area is a key wrinkle-prone region where the first sign of the aging usually appears. And up to date, there were various non-invasive devices that developed in an effort to treat the periorbital rejuvenations. For example, the ablative skin resurfacing or the non-ablative skin resurfacing. And let's be focused first on the periorbital agent of this ablative skin resurfacing. It was the most well-known would be the carbon dioxide one. And then resurfacing is one of the most successful treatment modalities. However, it created inflammatory hyperpigmentation and also the prolonged recovery time. And then how about the non-ablative procedures that included monopolar radiofractional systems and combined infrared light, bipolar, RF technology, or the high-intensity focused ultrasounds. It selectively induced the thermal injury within the dermis while sparing the overlying epidermis. So the periorbital region is particularly sensitive areas that anatomically vulnerability and then greatly affect the facial appearance. So the options of less invasive treatments are becoming more popular. Let me grab a water. So what are those modalities for the tissue restructuring divided in these three categories? The first one would be the radio frequency. The most well-known one would be the Thermarch. And the temperature it created would be less than 55 degrees Celsius. And then it created a suboptimal neocollagenesis. And then the depth is usually less than 3 millimeters. And then also it's kind of difficult to gauge the exact depth. And then so it's more like giving and providing a bulk tissue heating in order to induce the collagenesis. And then the second one would be the one we just mentioned, the micro-focused ultrasounds. And it provides the 60 to 70 degrees Celsius energy, heat, and then the collagen denaturation and optimize the neocollagenesis, which it targets to multiple tissue layers. This graph and this chart was introduced very early in 2012. At the time, there's only the mainly the people using with ULTRA. But I think the idea were very similar to that we're trying to highly precisely deliver the energy that's spaced injury for faster healing. And then the ablative laser, it gives a 100 degrees Celsius induced tissue vaporization that would be less than 1.5 millimeter superficial depths. Although it's highly precise, but the space injury or faster healing, but actually it might induce, we saying, the post-inflammatory hyperpigmentation. Let's make more like a fast, simple comparison. The ULTRAFORMER 3, the depth is about 2 millimeter. And then compared to, if we're trying to use periorbital, that would be the 1.5 millimeter from ULTRA. Also the Samaj, there's the 1.1 millimeter area it provide. The active region for the ULTRAFORMER 3 would be around 25 millimeter, which provides 26 TIZ. And then thermal injury zone. And compared to the ULTRA would be 14 millimeter and 10 TIZ. The Samaj would be about the area that give rise to the heat. That would be 0.25 centimeters square. The recommended shots for the periorbital, it says 120 to 150. But I have to say right now, nowadays, I use 150. I use 300 for all the top, starting from the infraorbital all the way to the forehead. So I divided 150 and 150. And what I'm doing mostly right now is would be 70 on the forehead and 40 and 40 here. And then the same applied to my right side too, of course. So for the ULTRA, that would be about 250 shots that recommended. And as for the Samaj, that would be 450. The time consuming, if we're providing 150 shots, that will be around 8 minutes that's given by ULTRAFORMER 3. And then the accumulative energy considered to be high. So what's what we might have to be afraid of? Actually, I have to say minimum. The complication for this micro-focused ultrasound, the erythema might be very mild and transient. The pupilla very transient. And then the post-inflammatory hyperpigmentation, actually, I don't see any from my patients. And then wheal striation, none. There's no subcutaneous nodules because of the depth, and edema minimum. And then as for the moderate, that might be the transient dysphagia, motor nerve paralysis, and not actually for the periorbital region too. Severe prolonged is not reported, and none of the case been reported. Okay, so what's my experience? At very first, I was trying to use this MF2 periorbital. I'm giving at very first, all right, only 75 shots to see what will be happening after 1 month of follow-up or 2 months of follow-up. And this is the protocol. The patient washed their face with the mild cleanser, of course, and then I put on this topical anesthesia for 30 minutes prior to the procedures. I have to say this topical anesthesia in Taiwan is routine to provide the topical anesthesia. Even it might not be as discomfort or the pain might not be as vivid, but as for the patient's comfort, and then they feel it's better to have the topical anesthesia. So it's very common in Taiwan. So for all the cases I have done, there's no noticeable side effects, including the epidermal shedding, crust formation, or bruises. Patient reported minimum pain during the procedure, and all the patients showed objective improvements with their periorbital wrinkles after 2 sessions, and then they were all satisfied. Let's show some of my clinical pictures. This is a 56-year-old female, and then after 1 session, and the infraorbital laxity seems to be improved. And then also there's the improvement of the fine wrinkles. And then the patient feels that her periorbital region were brightened up. And then also some kind of the lightening of the pigmentation. And this, I think this is kind of dramatic too. At first, I didn't actually expect. I was only trying to see if there's the wrinkles improvement. But actually what I see is the infraorbital laxity, the infraorbital laxity improvement as the tightening effect, especially in the infraorbital region. And this is from another view. So I follow up the same patient in 10 months. So at first in the baseline, and then after 8 weeks, and then post-procedure 10 months. So we're expecting this 2mn cartridge ULTRAFORMER 3 application around the periorbital region might last about 10 months to 1 year. But I think this is about the time that we can tell the patient that they may try the second to do the treatment again, and in a period of about 10 months to 1 year. I think this is kind of, but not in a very too short period of the time, in order to let the decollagenesis to provide the new neocollagenesis, also not to damage our skin too much in a too short period of the time. So I think post-procedure, 10 months, 1 year, that would be a very good idea. And for this patient, 2 sessions and 12 weeks. This is what I see about the infraorbital region. And this, I can see a bit of tightening effect. But of course, this patient, at first, the infraorbital laxity was not as vivid or severe or as prominent as the previous patient. And this is after 2 sessions post-procedure. And the patient is just very satisfied with the result. It's 10 months post treatment. I can see there's the improvement, and also the treatment effect actually lasts for 10 months. This is another patient right after the procedure and 2 sessions. It's another view, the infraorbital region. This is another patient, 12 weeks post-procedure. Actually, this patient was another patient that I did 300 shots at once. In compared to prior patients, I do 150 at first, and then 150 in a 2 weeks period of time. What I'm showing here is this one patient with a bigger eye bag, and he doesn't want to have the surgery right away. This is 12 weeks post-treatment. I have to say, there's no significant improvement, either from my perspective or patient's perspective. What I'm showing here is there's always, of course, a limit to the non-invasive procedure, but actually, we can see there's a bit improvement here. But of course, originally we're expecting if there will be more. So what I'm saying is this: if your patient have a bigger eye bags, so we have to tell them this might provide some beneficial. But so if you expecting the result to be similar to surgical treatment, that would be totally different story. But actually, the patient after 12 weeks, we can see this improvement. Next, we go to the pigmentation. There is a paper that published in 2015, and also by our doctor friends from Korea. And then they actually did this study on mice. At first group, there's no irradiation on my skin. And then they have done the UVB exposure irradiation with no treatment. And the group 2, and then the group 3, after irradiation, then they did the treatment of HIFU, and then with 0.1 joule per centimeter, And then the group 4 would be 0.2 joule per centimeter, and to see what would be the changes that can be expected. For the group 1, of course, there's no irradiation, so I don't see the hyperpigmentation in the DE junction. For the group 2, we see after the irradiation, without any treatment, there's the hyperpigmentation. But with the mice that received the HIFU treatment, we see that there's actually the improvement or the lightening or the hyperpigmentation in the DE junction is not as severe or vivid as what can be expected or compared to the group 2. And of course, group 4 with a higher energy, it seems that hyperpigmentation, post-inflammatory hyperpigmentation along the DE junction is even lighter. So they were saying group 1, group 2, group 3, and group 4. They're judging the differences values of the changes of the darkness from dark to light. I was saying that by using, and at the time they used this HIFU 1.5 millimeter transducer, the ultrasound energy delivered beneath the DE junction and upper dermis. And then the effect, the mechanical destructive effects that induces by the vibration and frictions that can eliminate, and that was the conclusion, all right? Eliminate the melanin and then pigmented debris from the epidermis and upper dermis. This is one of my patients around the periorbital region after 2 sessions post-procedure. Okay, so this is the pigmentation, and then we go to the neck. Okay, I was thinking, let's see if we can have different indications by using this MF2. So what the energy I use, sorry. The energy I use would be 0.4 joule with 25 millimeter 26 TIZ, 1.4 pitch. And then 1 session, 300 shots, 150, 150 to each side. And then, well, the photograph were taken at baseline and then immediately post-treatment and then follow up in 4 weeks. Excuse me. Follow up in 4 weeks and 8 weeks. And then I also assess the patient, we call it investigator global aesthetic improvement scale. And also the patient also subjectively thinking or give the assessment of the improvement. Here goes some clinical pictures. The IGAIS, the score I given was about 1 for this patient, a very mild improvement. But the patient self-conscious give the subjective score of about 2. And then this is from the other view. This is another patient. And then for this patient, he's about 65-year-old male. The scale is about 2 given. And then for himself, he felt it's about 3. 1 means mild, 2 means moderate, and 3 means very significant. I have to say, of course, I still see the deeper wrinkle. But this a minimum or mild tightening, but the patient himself feel the improvement is very strong. So I trace back some of the papers that published also by the Korean doctors. They were assessing this tightening of HIFU in other parts of body. And then they're always, I come into a conclusion that from the report or from the data they shown, the investigator global aesthetic improvement scale seems a bit lower compared to the subjectively the patient given to themselves. The patient, that means the patient feels the improvement are more significant compared to whatever were given by the doctors. This is another paper published, and they used the HIFU treatment for the wrinkles in the 7 different facial areas, published by a group of friends from Korea, doctor friends. And then also the same thing, the physician's evaluation score compared to the patient's satisfaction score, the patients are kind of higher compared to the physician himself. So what I'm saying is this a HIFU treatment, the patient's satisfaction was higher relative to the evaluation by the clinician. So not only result in the lifting and tightening and improvement of wrinkles, but also the skin tone, the facial contour, also the subjective symptoms such as the tightness or tension of the skin. The tightness and tension, I think the patient can feel much, much stronger compared to the physician. So come to the conclusion that I think the MF2 cartridge of the ULTRAFORMER 3 system can be a very good option for treating the periorbital and also the neck fine wrinkles, laxity, the brightening with no downtime, and a relatively low risk of side effects and the patient discomforts. Of course, there were further studies that were thinking of more objective grading scales and measurements, and also including some more histological studies. Further innovations, we're expecting that delivery of the increased energy to a more structural levels, and also the improvement in the treatment algorithms, including the higher intensity, more passes, or the vectored treatment lines, or different dermal, subdermal depths, increasing the tissue tightening, induction of the more collagenesis, or to a new renewed thin dermis, and then minimum side effects. And benefits for practice, I think this focus acoustic energy and it's converted into heat and device, we can have a predictable and reproducible results. And this non-ablative technologies and micro and macro cartridges for the maximum results. And also we can use this MF2 from the ULTRAFORMER 3 to a more narrow and sensitive regions in the face in a safe and effective way. Can be an alternative kind of to the Botox and also to the invasive surgery. Can be an alternative or kind of combination to it. Thank you, and that's my sharing, my presentation. Thank you for staying with me. Thank you.
Thank you for your presentation, Dr. Jonathan, and it was quite impressive. Now we have a Q&A sessions. Please tap chat button at the bottom of the screen and type your questions. Dr. Jonathan will give you an answer via speakerphone. Thank you. Any question? Dr. Jonathan, can you see a question?
Yes.
Yeah.
Okay, this one question and saying that for Asian neck, let's say a Turkish neck, can we give filler 2 weeks or the HIFU? I have to say, the filler that we use to fill up the neck lines, that's we give the injection in the dermal level. So I think, and after, and this HIFU, this is about, we're saying about 2 millimeter down the skin. So I think relatively, I think it's okay, it's safe. And then I think it may provide expected better results. Because sometimes after we do the filler injection, there might be some of this, we say pearl or with this necklace, more like a necklace kind. So after as what I'm expecting is a HIFU result might smoothen that out and make the filler more generally distributed, but also induce some more collagenesis around the neckline.
All right, thank you, Dr. Jonathan. And any other questions?
Yeah. Thank you. Thank you for the song. Okay, there's a doctor were asking about, is it okay to provide the HIFU after the usage of fillers? I think 2 weeks, let's say we have the filler prior to the HIFU, let's say 2 weeks, I think the filler should be stabilized. And I think also the HIFU, the 2 mm, I'm using the 2 mm on the leg line. I'm not saying using the 4.5 or 6 mm depths. I'm only talking about the 2 mm cartridge. I think that can be beneficial in a way that when we're doing the filler around the neckline, sometimes it really depends on the filler's substance and also the quality. And sometimes there might be some, we say blip, or we said the pearl kind. So I think that the HIFU, after introducing the 2 mm HIFU, it can smoothen out, but also it can provide some benefits around the structure to induce more collagenesis. So I think 2 weeks after the filler injection and then give the HIFU treatment should be okay and safe. Okay, just another question, and thanks to Dr. Xu from Taiwan. They're saying about 2 sessions with lower shots compared with 1 session and higher shots. Which one do I prefer? After this different studies, at first I do 2 sessions with lower shots compared to 1 session with more shots. I think there's 2 benefits. One, not only clinically, I see more improvement of 1 shot with, 1 session with more shots. I'm talking about 1 session with 300 shots. I think I can see a very good or comparative benefits compared to 2 sessions. But also, I think that's also saving a doctor's time because the patient comes and then you have to provide those anesthesia and then the waiting times. So I think 1 session with more shots will be okay, will be good. That's how I recommend it.
Thread lift.
Yes. Yes, I combine the thread treatment with the HIFU. But I have to say, in the hospital-based in Taiwan, we don't have much thread product to choose. And then what do I have is the more like the thicker thread, and then it goes to the deeper, let's say sub-Q region of the face. So I think it should be okay, and then okay to combine with the HIFU therapy. And actually, we're talking about different mechanisms, and the way of inducing the effect would be different. HIFU is using the heat energy in collagenesis, and as for the thread, it's the lifting effect. And of course, the thread itself can induce some of the collagenesis too, but I believe we're combining 2 different mechanisms to provide the results. And then if we're trying to combine the HIFU and the thread treatment at the same time, I prefer, of course, do the HIFU first and then the thread. But I have to say, usually I don't do it at the same day. Because I think the HIFU, sometimes after the treatment, there might be a bit swelling and the blood flow will be a bit faster. So right after the thread, the bleeding might be relatively a bit more. So I do not prefer to have the HIFU and the thread doing at the same day, at the same time. But it's okay to combine the 2 treatment together in different days. And then how do I handling the pain? As for the pain, for the 2 mm, or we said the shallower cartridge, 2 mm cartridge, the topical anesthesia would be just perfect. Sometimes the patient might not even need the topical anesthesia. Let's say 6 mm. I think sometimes the patient might also need some oral painkiller or pain control. I do not prefer, and I don't provide those general anesthesia to any of those patients trying to do this treatment. I think oral medication, pain control if necessary, because I need the patient's reply during the treatment. I think communication during the treatment is very important to me. Okay, here comes the question of periorbital rejuvenation. Do I use the 0.4 joule? Yes, I use the 2 millimeter, 0.4 joule, 1.4 pitch. And for most of my patients, but I have to say, for some very sensitive patient, I might have to reduce the joule to 0.3. Very sensitive one, but that's very, very rare. I mainly provide a 0.4. And then how I align the cartridge. Of course, with the 0.2, with the 2 millimeter cartridge that's given, that's invented by Classy. Let me take out my glasses. Sorry, okay. I provide the cartridge alignment along the lower eyelid. Then some of the shots, I will go like this. I'll go like this. But during the treatment, I will ask the patient to close his or her eyes and look upward. So it's more like you have your eye closed and then eyeball looking upward. So I can reach more closer to the infraorbital line, the edge of the lower eyelid. I have to say, yes, the last question. So whether every patient, a doctor always uses topical anesthesia, I have to say, because in Taiwan, most of the patients are used to have topical anesthesia for most of their aesthetic treatment. And so the patient will feel that with the topical anesthesia, they feel that they're being treated differently. So it's more like a protocol. So most of my patients, they use the topical anesthesia only for those patients that they say, no, I don't need the topical anesthesia, or they have the contact sensitivity or contact allergy to the topical anesthesia. For those kind of patients, then I will just skip the topical anesthesia part. Okay, there's one question and saying about how often can the patient come for the periorbital HIFU every month? No, as what I said, I prefer now to provide one single session with more shots. So I use 2 millimeter. I think the newer design of the 2 millimeter cartridge, it's better designed in a way that I can reach. I'm also answering the very last question from another doctor. For the newer design of the new 2 mm cartridge, that I can reach the edge of the lower eyelid better, and then reach those particularly angles better, and I can see how I get in touch, how I contact with the skin. So can we place the cartridge on the lower eyelid? I mean, inside the infraorbital rim. Yes, I put the cartridge because there's an angle of the cartridge. Sorry, can you get the cartridge to me? The 2 mm cartridge. I'm getting the 2 mm cartridge, so I can show it right away. And then, so I align the cartridge right on the infraorbital region, and then actually almost touching on the edge, because there's a slanted angle. So here comes the cartridge of 2 millimeter, because there's a slanted angle. So I can, in contact, let's say I have my eye closed and look upward. So actually the line here is actually the point that providing the energy, or the TIZ, the thermal injury zone. That part will not get in touch with the eyeball part. So it's safe relatively. But if you're thinking to align parallel to the edge, in this way, it's better to pull the lower eyelid down a bit, then have the cartridge towards downward. So in a way that you will not provide the energy upward to the eyeball part. But I have to say, relatively, it's still safe and very safe in a way that I think we talk about why 2 millimeter, because the infraorbital region, only the epidermal and dermal part, we're talking about almost 2 millimeter, not even including the subcute, the fat part. So it will not reach, that energy will not reach that deep. But of course, if we're doing this way parallelly, I still prefer safe counts first, like downward. That would be better. And then, I'm sorry, one question they were asking about, I kind of jumped. How often can I provide the periorbital treatment? I prefer one session with more shots. And I also mentioned about we need the tissue after the injury to let them heal. I don't want to provide the destruction right away. So at least I provide the treatment 6 months above, or around 10 months, because the effect can last about 10 months to even 1 year. So maybe about at least more than 6 months, that I think that would be good enough. Or even the patient, if the patient wanted to have the second treatment, and then if they cannot provide the budget that fast or that early, then maybe we can do it about 10 months or 1 year. That would be good.
Any more questions, everyone? So otherwise, we can finish it off. So thank you for attending the classes webinar meeting, and I'm looking forward to seeing you again. Thanks, everyone.
Thank you.
Thank you.
Bye-bye, doctor.
Bye-bye.
Bye-bye, everyone. Very happy.
Bye.
Thank you.
Very happy too. Thank you.
Bye. Be safe.
Thank you.
Thank you.